Well, good morning, everyone. Thank you, Laura, for the kind invitation. I've been a student of these webinars for several months, maybe a year now. So it's nice to be on the other side of the glass. And what we're going to talk about is sort of a combination of both of my worlds. I live in the emergency medicine world, and I also live in the pilot world, obviously. So thank you. As Laura said, your questions, please send to her, and we'll do our best to answer what we can. Okay, a little bit about me. I'm an ATP, both sides, airplane, helicopter. I don't read slides. You could read that. I'll keep that up just for a moment. I'm a FAASTeam representative here in the Farmingdale FISDO here on Long Island in New York. And master instructor, a couple of things. I was AOPA Flight Experience Training Award Distinguished Instructor this year, which I'm proud of. And that's a little bit of my flying background. And probably more pertinent to today's presentation is my emergency medical background. I've been a New York State EMT for 42 years, which makes me old. And 15 of those 42 years, I was a paramedic. There's several levels of first responder in New York State. Most states are very similar, where you're an EMT, which is basic life support, a paramedic, which is advanced life support. And when I did this more, when I was more in the emergency medical side, I was a paramedic, and now I'm an EMT. I've sort of downgraded my certification to emergency medical technician. I was a New York City police officer for 25 years. I worked with the Newark Police Department. I'm an instructor in emergency medicine in several techniques, several disciplines, I should say. And I'm a lifetime member of my local volunteer ambulance corps. So, what do we hope to learn today? I want you to plan for, recognize, and respond to an airborne medical emergency, primarily a passenger on your plane suffers a medical event. There's certainly limitations of what we could do in flight because GA aircraft are generally very small. There's not a lot of room to work around. I want you to utilize your aeronautical decision-making skills and techniques. Apply the knowledge to make decisions in flight regarding the medical emergency. And then I'm just going to go over some very basic tips, techniques to respond to a medical emergency. What I hope to do, I hope I sort of whet your appetite that you'll go out and get some formal training. It doesn't take a long time. It's usually a few hours, and you can really learn some life-saving skills that not only apply to aviation, they apply to life. Okay, so how did this presentation sort of formulate? Where did it come from? And as I mentioned, I have an emergency medicine background and the flying background. And it always troubled me that we never talked about this in flight training. What if a passenger gets sick? There's certainly no competency required of a PIC. There's no training required of a PIC. And I found that you're more likely to deal with a medical emergency in our flying lives than a aviation emergency, which is a good thing. We do all the training for emergencies, EPs, and all of that stuff, and that's wonderful. So as I mentioned, you're the pilot in command of your aircraft. Your flight gives you a lot of authority and a lot of responsibility. So that's the hope that you'll seek out some training and be able to deal with this type of emergency. So today's topic, very dynamic, very challenging. It's your responsibility to determine the course of action you would take. It may be different than the course of action I would take. We'll do a couple scenarios at the end, and I think you'll understand what I'm talking about. We will, some of us may have a differing opinion of what we would do. And nothing changes, pilots. Our actions in a medical emergency, our first responsibility is fly the aircraft. Regardless of what's going on inside that aircraft, we have to make sure we fly it safely. So aviate, navigate, communicate, nothing changes. We will keep that mantra going, regardless if it's in a medical emergency, aviation emergency. A legal disclaimer, just got to make sure everyone understands. Today's presentation gives you tips and techniques. It doesn't imply any certification. It doesn't determine any competency of any of these. It's highly recommended you get formal training in some of the things we're going to talk about. Real quickly, the Good Samaritan Law, what is it? All 50 states have some sort of Good Samaritan Law. And to summarize the slide, as long as you act responsibly, reasonably, and to your level of training, you cannot be sued. The example I always use when I teach in the outside world is you're inside a room that's on fire, it's burning, there's explosions. I drag you out of that room out to the outside. In doing so, I break your arm. You say, hey, thanks for saving my life, but you broke my arm. The courts are going to say, look, his actions were reasonable. You were going to die if he left you there. So he pulled you out of that burning room. That was reasonable. So you can't sue them. As I mentioned, each state has their own Good Samaritan law that all pretty much closely resemble each other with some minor differences. You're supposed to get the victim's consent. If they're unconscious, the consent is implied. So Good Samaritan law will cover you. So before we even take off, some pre-flight considerations. We all do our pre-flight planning. We take care of the aviation side of the house. I'll assume everyone does a really nice job with that. And then, but have you ever considered your course of action if a passenger has an in-flight medical emergency? Do you fly with people that have a known medical history? Perhaps an elderly relative, a neighbor, a friend, a parent, younger person that has a medical history that could impact the flight. Do you carry a first aid kit? Is it accessible? Is it useful? Talk about that in a few moments. And where would you land if the medical emergency was determined to be life-threatening? Whenever we fly, we always have our alternate airports in sight where we're going to go. But what about a medical emergency? A little different. The aircraft is under control. And I'm going to suggest a couple of tips in a moment of where I would go. What would happen if the front seat passenger suddenly became incapacitated? It has happened. They slump onto the controls. If someone gets sick or nauseous or has an accident in the plane, you're flying it fine, but what about the smell? Many pilots have reported to me that the smell really was distracting, very overpowering. And the GA aircraft is usually very small, very limited to what we can do in flight. Medical history, we talked about, someone has a cardiac history, someone suffers from COPD, some of these things. Remember, the higher you go in the atmosphere, the pressure decreases. So we have some O2 concerns. Maybe we'll have to fly a little lower. If you are going to fly with someone that might have a history, you might want to put them on supplemental oxygen well before the regulatory requirements. Make sure they feel fine for the entire flight. All right, where to land? Where would I land if I had an onboard medical emergency? Well, if you're utilizing flight following in your IFR, you're already on with a controller. So you could just declare the emergency, state where you're headed. If you're simply just flying, not talking to anyone, you have to find the frequency and land. Generally, a towered airport, the class B, C, D airports, generally have some form of air rescue firefighting or airport police that will have training. They can assist you. And the tower can coordinate EMS response to prevent confusion when responding to a call in the airport. As we all know, these airports are huge. The first responders may respond to the north side. We've landed and taxied to the south side, the west side, and there's going to be some confusion in the response. So the tower can do that for us. We could ask, where am I going to land? Let's say I choose JFK, airport that's just west of me, here where I fly all the time, or Minneapolis, St. Paul. They're large, they're complex. You would advise the tower, we're unfamiliar. Where is the best place to meet EMS? It might not be the FBO. For example, at Kennedy, they have a building 269 where the police are located. They probably have you taxi to that building. You could ask for progressive instructions. And if you're landing at an uncontrolled field, who's calling EMS? Obviously you're going to have a lot on your plate. And do you know the proper street address of the airport? I know I'm landing at Farmingdale Republic. What is the address? I have no idea. The 911 dispatcher likely would know what airport you're talking about, but they may not. They may say, I don't know where that airport's located. So make sure you understand who's calling. And also remember, if they call, the locals may know the airport under a different name than the formal FAA name. It might be Ken's Airport. Everyone knows it's Ken's Airport, but the formal name is quite different. So here's an example of the Class B, New York, where I fly. Republic Airport is outside the B. It's below the B, but to the right there. Where would I go? I mean, you have a multitude of airports here. You have Kennedy, LaGuardia, Newark, a lot of towered fields, uncontrolled fields. So the options in this area are many, but I would recommend I'd probably try to go to a tower controlled field for the reasons we mentioned before. And here's a taxi diagram of Kennedy. I'm told Kennedy has 25 miles of taxiway. So you can see how confusing it is with all these turnoffs and different taxiways, parallel taxiways. You definitely would need help taxiing once I landed. I'd ask for Progressive, and they would take me to wherever I need to go. It could be the GA terminal. It could be an FBO. It could be a fire station. It could be in Kennedy here, as I mentioned, Building 269 is the Port Authority Police. All right, what would you do if you had a incapacitated front seat passenger? It certainly has happened. They slump onto the controls. And now I'm trying to fly the aircraft. I have this incredible interference. You can imagine the difficulty here. You can imagine the distraction. Could I hold them back with a shoulder harness? Maybe. Maybe a backseat passenger can hold them back in the seat to get them off the controls so I can land. I would submit you certainly have an emergency at this point for two reasons. One, a controllability issue of the aircraft, and the medical emergency as well. And the unpleasant smells. In my times as a first responder in EMS, the smells I find were the greatest challenge. Some suggestions: you could pop a surgical mask on that's smeared with toothpaste, kind of suppresses the smell, or any other organic substance that'll make it smell better. Vicks Vapor Rub, you could rub under your nose. It's very strong. It could try to suppress that smell. A police trick: we carried a small bag of coffee grounds, just laid it out. I'd put it on my lap so I get that smell of coffee as opposed to the unpleasant smell. Mints, some flavored gum could help. And then last but not least, I'm not endorsing any product, but there are commercially available products. They're odor blockers. You go to Amazon, eBay, just put in odor blockers. Stick is one of them. Someone told me it's not available anymore. It just helps you to suppress those very, very strong smells. And the limitations of GA aircraft. Just randomly picked 3 aircraft here. Think about it. I had a passenger suffering a medical event in the rear seat. I'm the PIC in the front seat, the left side. Very little I can do. I'm not able to crawl back there. I'm not able to have them come up front and I could assist them up front. So recognize the limitations of GA aircraft are many. Most likely, I have to get on the ground to treat a medical emergency. Right. Overall, all in-flight medical emergencies, you're the pilot in command. You determine the course of action you're going to take. It's not ATC, not a doctor on the ground or another aircraft, not another pilot. I decide I'm going to airport A. That's your decision. I decide I'm going to do plan of action Y. That's your decision. All right. All airborne medical emergencies, people, when they fly with us, they look to us as the authority there, calm and confidence. If you're calm and confident, that instills calm and confidence in a patient. Listen to your patient. What do I mean by that? Someone might have a medical issue and they might say something like, I don't know, I got a bad feeling here. That's an important thing they're saying to you. They're telling you, yeah, I have this issue. I've had this issue in the past, but something's wrong, something more here. So listen to your patient, listen to what they're saying. Common sense should prevail. Common sense isn't all that common, but common sense. Hey, I have a real bad feeling here. That increases the emergency in my mind a little bit. And if any passenger, any cardiac issue, shortness of breath, difficulty breathing, generalized abdominal chest pain, or stabbing back pain, I would recommend it's a land as soon as possible situation. Generalized illness. Hey, I'm not feeling good. What's the matter? I don't really know. Maybe I didn't sleep last night. Whatever. We're going to be calm, confident, positive, reassure the patient, allow them to be as comfortable as possible. We call it in the medical world the position of comfort. They will find that position. Hey, if I lean to my left, I feel better than if I sit straight up. Allow them to lean to the left. You'll just ask some general questions. Any idea why this is happening? No, it's never happened to me before. Or they might say, listen, I have this condition. This is why it's happening. Why is that important? When I land, should they go unconscious? Should they go unresponsive? I'm the person that's going to tell the first responders, this is what happened. This is what was leading up to this medical event. Are they taking any medications? Are they allergic to anything? Just some very general stuff you could ask. Obviously, an unconscious, unresponsive person on your aircraft, absolute medical emergency. We have to get the aircraft on the ground as quickly and safely as possible. And I always think about steep spirals in a situation like this. We always think of the engine out or engine fire. We got to get down as fast as possible. A steep spiral could be used to get the aircraft on the ground as fast as possible because I have this medical emergency. Perhaps your next flight review, you could say to your instructor, hey, let's practice one of these. I don't want to do the engine out scenario. I don't want to do the aircraft fire scenario. I want to pretend I have a passenger in the back that's unresponsive. Can we do a steep spiral? Do it to uncontrolled field, tower control field, obviously let them know. And just practice that in case this is a third reason why you might want to be able to do that. Okay, some tips and techniques. This is information only. You do need some training. There's not a lot to it. I'm giving you these tips and techniques to help you make a better decision. And once again, I can't stress enough to get some formal first aid CPR training. I'm going to talk about our best practices. They're based from several nationally recognized organizations. However, there are some local protocols that may differ. You don't have to point it out to me. I understand it. People will say, in Iowa, we do. I understand it. It's not wrong. It doesn't make mine right or wrong. It just, people sometimes differ a little bit on a particular practice. Be guided by your local authority and what they say is their best practice. All right. Learning CPR, first aid, stop the bleed. We're going to talk all about it. It's a lot of courses have flipped to a hybrid model. You could do the academic portion online and you do the physical skills portion. You meet with an instructor. You spend, an hour, 45 minutes. You demonstrate you have the skill and you're certified. I would recommend my CPR class that I teach on the outside is a 3-hour class. It covers adult, child, and infant CPR. It's a lot of fun. And once again, it's a life skill, not just an aviation skill. You could use it anywhere, out at a restaurant, on vacation, at your home with your family members. It's real good skills to have. I was out to dinner recently. The table next to me, a woman leaped up. She was choking. I leaned over. I cleared the airway, resumed my meal. But it was nice that I was able to intervene, know what to do, and quite possibly saved her life. I don't know if I did, but as I mentioned, it's a life skill, not just an aviation skill. All right, so let's start out with bleeding. I'm going to talk about the severe bleeding. Once again, you got to get some training. It can be minor, can be life-threatening. Most external bleeding is not severe, and it can be controlled through a method called direct pressure. And what is that? If you have a barrier, if you have gloves, use the gloves. You simply put a dressing on the bandage, direct pressure, meaning just put pressure on it. And that will, I'm going to say in my experience, having done this 42 years, 90% of the time that stops the bleeding. I might have to put another dressing on or two, but usually that does stop the bleeding. A direct pressure bandage, if you have a first aid kit, you simply put the bandage around it. It applies the pressure for you. You don't want to put it on too tightly. You would check their fingers and toes, make sure I didn't cut off circulation. Generally, most people don't. You just want to make sure you have pressure on the wound. How do we measure it? If I could fit my two fingers under the bandage, that usually means it's tight enough but not too loose. All right, tourniquets. About 15, 20 years ago, tourniquets were coming out of the curriculum. They found responders were putting them on too much, too often. And sadly, they're back in, primarily due to terrorism events, active shooter events, and they're for severe bleeding. It's going to be, there's no other option. Once again, training required. Stop the Bleed course does cover this. And Stop the Bleed is a national campaign. You see the link there, stopthebleed.org. It's a course that's usually 90 minutes or less. I've seen them 60 minutes, where you go and they're going to go over direct pressure. They're going to go over tourniquets. It's training that's designed for non-first responders that are at an event that's just simply overwhelming, an active shooter, a terrorism event, where professional help is on the way. There's a large amount of victims, and they just need help from anyone that can help. And don't forget, you could help yourself. If you suffer one of these severe bleeds, a femoral artery bleed on your leg is a severe one, you could apply these techniques before help arrives. People said to me, I'll never need a tourniquet on board. Well, you might. The picture on the left is a bird strike as it's happening. It's a screenshot right of the YouTube video. A large bird comes into the cockpit. The graphic on the right is the aftermath. It took out the entire windshield. The windshield itself, the shards could certainly cause a severe bleed where a tourniquet could be required, could be. So I wouldn't rule it out. Likely, no. Possible, yes. All right, one of my son, I'm an expert in this because my son gets nosebleeds all the time. Uh, Real easy. You want the person to lean forward. We do not want the blood and all that to drain back into the throat. It can become an airway issue. You just pinch the nose, and 10 minutes. I've never had my son not stop the bleeding after really 5 minutes. It stops it pretty quickly. You don't want them to blow their nose. The blood is clotting in there. We don't want to stick things up their nose. We don't want to cause an injury. I found this technique works 99% of the time. Okay, diabetic emergencies. I confess I do have diabetes, so it's near and dear to my heart. And what are some considerations that someone is diabetic? Most of the time, the patient will tell you, I'm not feeling right, I'm diabetic. Or sometimes they don't. They don't want people knowing, and I understand that. And if someone's unresponsive or someone suddenly went unresponsive, they might have a medical alert tag. They might you might see the insulin pump on their body. You might see a diabetic medication. If you're not sure, should I give sugar? Should I not? The recommendation is give the sugar. If they need it, it's helpful. If their sugar is too high, there is a way they can deal with that. I'm not going to add that much sugar that it's going to cause an issue. They often know the solution. Hey, I need to take a drink. I need to have a candy bar. They'll tell you, hey, if I just have a cup of juice, if I have an orange juice, very sugary drink, I'll feel much better. They'll tell you if they're conscious and they're able to, just assist them. Here's a soda. Here's I have a Snickers bar. I have a Three Musketeers, and usually, very often, they say, "Gee, thank you. I feel a whole lot better." You might offer, "Do you need to call an ambulance?" No, I don't. I'm fine. This happens all the time. Once again, a decision you make along with your patient. Okay, the foreign body airway obstruction. Someone's choking. The signs, if you look on the graphic to the right, the public service announcements always say the person will clutch their throat. You'll ask, are you choking? They'll nod their head yes. From experience, it doesn't go that way at all. They are in a severe state of panic. They're going to be flailing. Matter of fact, the last one I responded to, the bystander said, I thought there was a fist fight. The person literally flipped the table because they're in a state of panic. We're going to do what's known as abdominal thrusts. Uh, when I teach this, I actually don't show the video because the video gets very complex, very complicated. It's really just the way your hands go. If you could imagine, the lungs always have residual air. If they're choking, there's just a cork in the bottle. I'm trying to force that residual air up to pop that cork. So my hands just naturally go to the abdomen, and I try to lift them off their feet. I pull a little forcefully. Child, there's no difference in the technique. However, you do have to adjust yourself to the size of the child. And then if you have an infant, it's 5 back blows and 5 chest thrusts. You keep flipping the infant back and forth. Once again, I ask all of you to consider getting the training. It's, like I said, about a 3-hour course. And I have had several infants in my career, and it's a terrific feeling. I had one where somebody, I was working as a police officer. They passed the infant into the car. My partner and I drove to the hospital. By the time I got to the hospital, I cleared the airway. And what a feeling. I mean, the parents showed up. They were crying. I was crying. It was very emotional, but a very happy emotion. And I'm happy to report the young boy was fine. And you can do it on yourself. You could bend over a car fender, a wing, if I'm choking and I'm on the ground. And once again, the principle is I'm trying to drive that air to pop that cork. All right, somebody has a stroke. Really, the only thing we can do in the field is assess it. We're going to say, hey, I think they might be suffering from a stroke. We call it the FAAST assessment. And what does that stand for? FAAST is facial droop. Do both sides of the face move equally? If one side droops, that's a sign. A is the arm drift. You ask them to hold their arms at the same level. They should not move at all. If one arm drifts compared to the other, that's our A. Our S is abnormal speech. You say, hey, can you teach an old dog new tricks? And they'll just repeat it back to you. Obviously, repeat it back. There should be no slurring. It should be fine. If they slur, use the wrong words, or unable, a third sign. And then time is brain. What I mean by that is there are therapies in the ER they can do now, which can stop the stroke or reverse the symptoms and signs. However, time is brain. We have to get them there as fast as possible. All right, some heat-related emergencies. What are they? If you look on the graphic on the right, it goes from the bottom up in seriousness. Heat-related illness can affect anyone, including us as the pilot in command. And what do they normally start with? I feel maybe a little lightheaded, dizzy, muscle spasms. Heat exhaustion and heat stroke are what we're more concerned about. Heat stroke is what we call a true medical emergency, the top one. And the major difference between the two, heat exhaustion and heat stroke, heat exhaustion is the body will be sweating profusely. It's trying to cool itself. There comes a point where it can no longer do that. They're going to be red hot. When I touch them, you're almost going to say, wow, I could cook an egg on this person. They're no longer sweating. The body is literally cooking within itself. And we have to get that person cooled yesterday. And really, the only way to treat the heat stroke is to land and get them into the coolest water I can. And this is if we could put them into an ice bath, this is a true medical emergency. Inbound, I'm coming down from altitude. I'm going to loosen their clothing, try to cool them. If I have water around, try to cool them the best I can. We're trying to cool that core temperature. And as always, prevention is our best option. Eat light. The more I eat, the body takes more energy to digest it, producing more heat. Drink plenty of fluids, avoid caffeine. The best fluid, obviously, is water, lightweight clothing, hats to keep the heat off our heads. And then sprains and strains. How can we tell the difference? We can't. Only a X-ray MRI could tell if it's a sprain, a strain. We don't really care. Uh, people fall, they twist, getting in and out of an aircraft. They could, sprain or strain an ankle, a wrist. Our treatment is going to be, we're going to RICE it. That's an acronym for rest, ice, compression, and elevation. So rest, don't, if it's an ankle, we don't want them walking on the ankle. We want to rest that. Put ice 10 or 15 minutes for the first few hours, maybe a course over a couple of days to minimize the swelling. Compression, think of like an ACE bandage, a compression dressing. I want to keep that ice on the injury to reduce the swelling, and then elevate it above the level of the heart if you can. Obviously, an ankle, you have to lay them down to lift that body part, but a wrist, just keep it above the level of the heart. We're trying to reduce the swelling. They could take a pain, an analgesic if they want for the pain. That's up to them if they're not allergic to it. And no heat. It will increase the swelling and pain for the first 24 hours. All right, someone with a seizure, once again, it's something they often know they have a seizure condition. I have a dear friend who he'll tell me, Ken, I know, I feel it's coming on. So what do? I get him to a safe area, couch, I let him lay down. Little I can do to stop that seizure, except keeping them safe. I want to make sure they don't fall and hurt themselves. When we teach this in the paramedic EMT course, we always say, someone's on a train platform. We don't want them falling to the tracks. So, okay, keep them safe. Do not restrain them. The seizure is going to run its course. There's nothing I can do to stop that. Don't put anything into their mouth. They're not going to swallow their tongue. That's a myth. And I want them to, if jamming things in their mouth, I could cause a airway issue. If I break off teeth, or the object itself that I'm jamming into their mouth can cause an airway issue. When do I call 911? Most of the time, my friend, when he comes out of it, he's fine. I ask him all the time, do you need anything else? Do you want me to call? He always says, no, thank you. I'm fine now. And we go on. When do I call? If it's the first time seizure. It lasts longer than 5 minutes. It's repeated seizure. In other words, they seize, they stop, they seize again. There's a difficulty breathing issue, or they give you listening to your patient. Hey, Ken, I feel different than I usually do. We better call someone. Okay, anaphylaxis is a allergic reaction. It's life-threatening. Once again, we do call it a true medical emergency. We've probably heard of the EpiPen as the drug of choice to treat it. We have to give this life-saving medication now. Why? Because the body is swelling. It's swelling on the outside. The picture of this child on the right, you see the lips are swelling. They're swelling on the inside. And our largest concern is if the airway swells, it can cause, it could cut off their ability to breathe. So if it's a severe anaphylaxis, allergic reaction, a bee sting, peanut allergies, we'll probably all have a friend that suffers from one of those allergies. They may have an EpiPen available, and we want to treat it with that epinephrine right away. If they're conscious and breathing and they could administer it, we're just going to assist them. They probably will know how to do it. Because they're going to say, I'm going to inject myself with this EpiPen. That's fine. We just kind of stand by and make sure that they are able to do it properly. And then we'll see. They do have to get definitive treatment. What that means is the EpiPen is a fairly small dose. So if I'm exposed to an allergen and I have this reaction, the EpiPen works. Wow, it really has worked. I feel a lot better. If the medication wears off, because it's such a low dose, and the allergen is still present, the anaphylaxis will return. If someone is suffering from a anaphylactic reaction and someone else has an EpiPen, you can give it, particularly in New York State, you're allowed to give it. And it does have an impressive safety profile. There's very few side effects to it. So I'd recommend if someone is there to give that. treatment. How do we do it? Right here, the directions. It's auto injector. You just inject it into the thigh. You hold it for 10 seconds. It administers the medication, and that's it. Then you just monitor them for, and I will say, most of the time, you will see improvement. This is a true medical emergency. So now we have two. We have anaphylaxis, we have heat stroke, where they need treatment. And motion sickness. So we've all probably experienced that some way or another. Very commonly, what our passengers, I just had a passenger recently, she got motion sickness. There's a million remedies out there. There's a lot of, we all have our own little way of doing it. These are just suggestions here. I could probably fill up 5 slides with different, have them look outside, get some air, get them off the screen, their iPad, iPhone, let them look around, aromatherapy, a pleasant smell. There's a host of natural remedies you could use, pressure points. There's some research that says if I hold a pressure point on my left wrist, that can reduce it. Some teas, lozenges. There's a whole bunch of things. In other words, I want to keep them calm, get them air, get them looking outside, not looking at their screens. And motion sickness. Make sure the motion sickness bags are within reach. As I mentioned, I just recently had a motion sickness passenger. She was sitting right next to me in the right seat. I could not reach the motion sickness bags. They were in my flight bag all the way in the back, and it was just me and her. I could not reach them. So it turned into a little bit more than it should have, and that was entirely my fault. Okay, Narcan, folks. Opioids is a crisis in America, not just, and I really put this up here, not so much the aviation side. It's just good to have. If you happen to be at an airport, someone suffers a fentanyl or heroin overdose, very easy to administer. I do carry it in my kit. I carry it in my car. I always have it just in case, I'm at a location and someone suffers one of these overdoses. Someone's unconscious, unresponsive, you spray it up their nose. If it's not an overdose, it's spraying water. There is no effect. If they are having an overdose, it can save their lives. Okay, CO poisoning. What are some of the symptoms? Headache, dizziness, blurred vision. You might smell the exhaust odor, often a common culprit. Act quickly. I would turn off my heater, try to get air in there, land as soon as possible. And a basic first aid kit. What should I carry? I get this a lot, and I always recommend. Once again, I won't read the whole slide to you. These are just ideas. Bandages, dressings, scissors to cut, a CPR face mask, some antiseptic wipe gloves. Common sense. Be your guide. There's commercial kits available out there or homemade. I generally lean towards the homemade ones because I like to sort of customize it to my needs, what I need. It doesn't have to be overly large. It doesn't have to have a lot of weight. I know we're always concerned about weight. Just the common things you might need. All right. Do medical emergencies affect the safety of flight? They certainly do. I just picked 2 random cases from the files of the NTSB. The first one, the student, a flight instructor on the dual instructional flight. The student says, I'm not feeling that well. The learner says, I'm not feeling that well. The pilot, they discuss, all right, let's go back to the airport. They became distracted. They don't lower the landing gear. And what do you know? They land gear up. Very common. So this medical issue affected the safety of flight. A couple of points I like to point out here, the unsafe checklist. The learner was fatigued. Was it feeling good? Probably shouldn't have done the flight in the first place. And, they got off their game. They didn't do the landing checklist. They were distracted, and the medical event caused the gear up landing. The second one here, I picked because this happened to me. Passenger was ill, couldn't reach the sick bags. This pilot decided to make a precautionary landing on a dirt road. During a landing flare, a wind gust caught them. They drifted left and they hit a tree and impacted the ground. So once again, for the want of a air sick bag, you had an accident. All right. I know it's 11 o'clock. Some people might have to bow out. I'm going to go through a few scenarios. Uh, no wrong answers here. I want you to think you're the pilot in command. What would you do? So, first one, we go to Martha's Vineyard, a flight I often take. It's off the coast of Massachusetts. It's a nice flight from Long Island. We're on the way back. We're at 8,500 feet. Uh, I always try to hug the shore, but there's a point where you have to kind of turn over the ocean to get back to Long Island. Suddenly, one in the back seat, one of your backseat passengers says, "Hey, Dave looks dazed. It looks like his face is drooping." You suspect a stroke. You do a rapid, fast assessment. You confirm you think this is a stroke. So, what would you do? X marks the spot where you are. Those are your immediate choices. You have Elizabeth Field right below you on Fisher's Island, or you have Groton, New London, Connecticut, a couple miles north. I would submit to you go to Groton, a Class D airport. You probably have some rescue services to help you. They are going to need definitive care. If I land on Fisher's Island at Elizabeth Field here, they would have to be transported via boat or medevac helicopter. They would have to get to a hospital from there. We're just adding the time to it. And however, real case scenario, because I just did a flight like this, Elizabeth Field right now, it's closed for paving till May 26th. But we knew that, right? Because of our pre-flight planning. So if I couldn't even land there, if I set up the approach and realized, this airport's closed. All right, so I'm right over Fishers. I land there. I'm very close to Groton. I would go there because EMS will likely arrive quicker. Or I'm just going to go to East Hampton. Time isn't that critical here, and I'm sure Dave will appreciate it. Got him back to Long Island. Uh, I think I've demonstrated a choice B here. The second one, probably our best choice. We're going to get Dave definitive care as soon as I can. All right, another quick scenario. You're coming back from New Haven, Connecticut. We're crossing the Sound once again. You're there with a friend and his sons. He suddenly says, fudge. He's got a small cut on his finger. Your friend's an off-duty police officer. He puts some napkins on. It seems to be the bleeding's controlled. What actions would you take? I have to go back to Yale because Yale, New Haven is legendary, and they are. This has to be treated by the best. I would go to Farmingdale Republic. It appears controlled, confident the boy is fine. Do nothing. It isn't your son, and you could get sued. I'll submit to you. I would choose choice B here. I would just continue on the Republic when we land. Maybe say to the dad, "Hey, you maybe get someone to look at that if you think," or let the dad make that decision. What are we going to do with this young boy? All right, I'm going to go to another scenario because I want to just for time. All right, I rotate from the airport. As I'm climbing out, a passenger screams an expletive. They slap their forearm and he says, "A bee just stung me." As he climbs out, he says, "I feel weird." You see the hives swelling, and he says, "It feels like my throat is closing." What do we have? Folks, we have anaphylaxis beginning. It's choice A is really the only possibility here. I got to land and get back to the airport, or I have to land immediately. I'm not going to continue. I'm not going to look for signs of extreme distress. They already are there. It's not a bee sting reaction. It's not going to pass quickly. This can become life-threatening very quickly. Okay, I'm going to go to a couple of scenarios just for time. So summary, pre-flight, pre-plan, think about these things before we fly. Our emergency thinking does not change. Aviate, navigate, communicate. A basic first aid kit, make sure it's within reach. I think I've stressed this enough. Get some formal CPR first aid training. Initial recurrency. Once again, it takes a Saturday morning. It takes 3 hours to get all of this. Anytime I do a presentation, I do end it with this slide. I say, less than 1% of the population of the United States holds a pilot certificate. We are elite. It's a proud thing. I'm very proud to be a pilot. But our Spider-Man friends will remember this quote: with great power comes great responsibility. People count on us. They look at us as the authority here. And we owe it to them to at least be able to get them to care to possibly save a life. All right. Those are some resources, folks. I'll leave this up here for a moment. If you want to screenshot it, I'm sorry, if you want to take a picture of it, those are just resources, folks. There are thousands of them out there. These are just a few select ones that you might want to get some more information from, and it gives you, ideas where to take some courses. You could look at local community organizations, local fire departments, ambulance corps often sponsor trainings. They're usually excellent. Just some more resources. And last but not least, I know we're tight on time, and I apologize for that. I rushed through a little bit. I wanted to get as much as I could in. There's my contact information if I'm willing to share the presentation, but you do have to email me to let me know so I can send it to you. There's my phone number. If you have questions, concerns, please let me know.